My name is Vedant Kulkarni, and I'm all the way in California doing this remote presentation for you. And it's a wonder of our connectedness through the internet that we were able to make this connection so that I could give you this presentation today. And it's really my pleasure and honor. I have no disclosures of financial relationships or disclosures of off-label or investigative uses that are relevant to this presentation. So just an overview of my talk. I'll begin with normal hip development, then talk about the pathoanatomy of neuromuscular hip dysplasia, and finally end with the evidence for hip surveillance programs. Let's start with normal hip development. To be on the same page, we need to first be speaking the same vocabulary. So the capital femoral epiphysis is the ossific nucleus of the femoral head, or the ball. There's also a part of the femur called the greater trochanteric apophysis, where the hip abductor muscles attach. The acetabulum, as you know, is another name for the hip socket. There are quite a few other important structures, including the labrum, which is the lining or the lip of the acetabulum, as well as the hip capsule. The proximal femoral physis is the femoral growth center, and the triradiate cartilage is the acetabular growth center. Focusing on acetabular development, the depth and the shape or morphology is determined by the triradiate cartilage, and this acetabular shape is determined by age 8. There's interstitial growth via the triradiate cartilage that contributes to the size and depth of the socket, and appositional growth via articular cartilage is very important, as you'll see. The most important determinant of normal development of the hip is concentric location of the femoral head in the acetabulum. That is, the center of rotation of the femoral head is inside the center of rotation of the acetabulum, as you can see in the normal diagram to your left. In the middle diagram, there is mild femoral subluxation. That is, the femoral head and the femur are starting to move outside of the socket, but not completely outside. You'll notice that the gray areas here represent exuberant or unopposed appositional growth of the cartilage that slowly obliterates the space that would be created by the femoral head subluxating. Essentially, what's happening here is remodeling of the socket so that there is no space, making it very difficult to have reduction of the femoral head into the socket for a round ball and a round socket at skeletal maturity. In the far right, the situation is even more dire. Here, the femoral head is dislocated completely, and you can see that the appositional growth of the acetabular cartilage is slowly obliterating the socket altogether. This underscores the importance of concentric location of the femoral head in the acetabulum early in life. Let's now talk about the pathoanatomy of neuromuscular hip dysplasia. Neuromuscular hip dysplasia is very different from developmental dysplasia of the hip. In neuromuscular hip dysplasia, the hip is absolutely normal at birth. Even in those children with cerebral palsy who are not walking at birth, their hip, if you take x-rays or do ultrasounds, is completely normal. However, there's progressive displacement of the hip over time due to abnormal muscle forces and skeletal development. This is contrasted to the situation in developmental dysplasia of the hip, where the hip is abnormal at birth, and the capsular laxity causes excessive motion, and the femoral head, which is abnormally positioned at birth, can be detected by an ultrasound. I make this distinction because it's important not to use some of the treatment algorithms that we have for DDH for hip displacement in cerebral palsy. We need a different paradigm. Because the displacement is progressive in cerebral palsy, this displacement is silent and slow. As you can see in this child, over the course of 2 years, there is slow progressive loss of range of motion and progressive displacement on X-ray before there's any pain. And so if we're able to detect the displacement early, X-rays need to be taken at multiple times during childhood for detection of this displacement. To assess the risk of developing hip displacement in children with cerebral palsy, we turn to the Gross Motor Function Classification System, or GMFCS. If you don't already know this system of classifying children with cerebral palsy, it's absolutely important in understanding the literature and in communicating with your colleagues. I've highlighted here the children who are ambulatory in green, the children who are marginally ambulatory in yellow, and those that are considered largely non-ambulatory in pink. GMFCS 1 and 2 children can walk without any handheld support. Those in the GMFCS 1 category can walk on uneven terrain and stairs without any support, whereas those in GMFCS 2 use handheld support for stairs. When you get to GMFCS 3, a handheld device is used for walking, such as a walker. And these children will use wheeled mobility devices for long distances, such as manual wheelchairs. For children in the GMFCS 4 category, they need self-directed powered mobility, such as a powered wheelchair, to be independent. Sometimes when they're younger, they may use a body support walker, but will require the assistance of someone else to help guide them. GMFCS 5 children will have limited head or trunk control and require full support for mobility. They're unable to power even a manual wheelchair. This system becomes very important in understanding children with hip displacement. In fact, the GMFCS level predicts hip displacement over time. You can see here that GMFCS 1 children have a negligible risk of hip displacement when it's defined as a migration percentage over 30%. When you get to GMFCS 2, this increases to 15%, and by GMFCS 3, up to 40% of children will have an elevated migration percentage. Consider that all of these children are ambulatory children and will be walking likely into their adulthood. And so, unless you look, you won't necessarily find that they have an elevated migration percentage. Children in GMFCS 4 or GMFCS 5 categories have a much higher rate of hip displacement, as you can see here, up to 70 to 90%. The overall risk of hip displacement in cerebral palsy is 1 in 3, a staggering number when you consider that cerebral palsy is one of the most common, if not the most common, cause of motor disability in children. There is a special case that I'd like to highlight, a group of children that has a higher risk of hip dysplasia than one would expect by their GMFCS level. This is the group 4 spastic hemiplegic type, those with dense cerebral palsy that involves half of their body, that has involvement of the pelvis and the hip. This is a child with such a pattern. Notice here that he has pelvic rotation, hip flexion, and hip adduction, as well as internal rotation of the hip, in addition to deviations at the knee and ankle. These children are at a higher risk of hip dysplasia, and therefore, in many of the hip surveillance guidelines, require a higher level of hip surveillance. Let's now talk about the untreated neuromuscular hip dysplasia and how it differs in children with ambulatory capacity versus those who are non-ambulatory. In ambulatory children, hip subluxation is the rule, and this causes progressive arthritis and pain over time, limiting function. Dislocation, however, is unusual. In children who are non-ambulatory, however, hip subluxation and dislocation are much more common, and this causes severe pain, pain with sitting, pain with movement, pain with normal care of everyday living. This is a child who came to us unfortunately quite late. Notice here that this ambulatory child has hip displacement in the marked difference between the two sides. He has spastic hemiplegia, and you can see that he has a flattened and deformed femoral head on the more affected side. In ambulatory children, if you're able to catch the disease early, the hip dysplasia is less severe. As you can see here, in the early situation, the hip migration percentage is less, compared to the late situation where more of the femoral head is outside of the socket. Perhaps even more important, in early hip dysplasia in ambulatory children, the ball has not yet deformed. The femoral head is still round, whereas in the later stages of the disease, the femoral head is actually deformed. In non-ambulatory children with cerebral palsy, the situation is a little bit different. Here, look at this child at age 8. About half of the femoral head is outside of the socket. By age 9, about 75%. And by age 13, the hip is completely dislocated. Between the ages of 8 and 9, the child had maintained sitting balance, had minimal cartilage damage, and potentially had the opportunity for anatomic reconstruction with a future that would have no or minimal pain with treatment. Contrast that to the child's situation at age 13, where she has profound sitting balance disturbances, cartilage damage, and only a salvage surgery is possible with poor results. This is what the child's hip looks like at the time of surgery, with complete cartilage loss with exposed bone, essentially end-stage arthritis, a hip that you would expect in a much older patient, perhaps an elderly patient in their 70s or 80s. Detection of neuromuscular hip dysplasia in non-ambulatory children is important because up to 20% of these children will develop a hip dislocation, and over half of these patients will have hip pain associated with that dislocation. We now have even better evidence that hip displacement matters in non-ambulatory children. The CP Child questionnaire is a questionnaire that was developed in Toronto that allows us to gain the perspective of the caregivers in the child's function. As you can see here from these diagrams, the total score of the child's function decreases as the hip migration increases, as does their health, and their communication and social interaction also decreases with elevated migration percentage. We can see that the child's hip displacement significantly affects their outcome. Let's now talk about the evidence for hip surveillance programs. Let's now talk about what hip surveillance actually is. There are 3 pillars to hip surveillance: the assessment of risk, the threshold for treatment, and understanding the whole child. Let's begin with the assessment of risk. And that comes to an assessment of their level of function. The gross motor function classification system level predicts the risk of hip displacement, as I described to you earlier. With patients with more severe involvement and lower function, as described by the GMFCS system, that is a higher number, have a higher risk of hip displacement over time. All hip surveillance programs in their guidelines stratify risk based on GMFCS as well as whether or not the child has a group 4 hemiplegic gait pattern. And the frequency of surveillance, that is the frequency of x-rays and physical exams, will increase as the child's GMFCS level number increases. Here you can see the GMFCS 1 or 2 children, the most functional, have the least amount of surveillance. Those with group 4 hemiplegic gait and GMFCS 3 levels will have an intermediate amount of surveillance, and those at the highest risk, GMFCS 4 and 5 children, will have the most surveillance over time. Next, we need to understand the threshold for treatment. With different physiologic processes, we have different thresholds for treatment. For heart disease, we use blood pressure. For diabetes, we use blood sugar. And for neuromuscular hip dysplasia, we should use the migration percentage. And these are the thresholds. For neuromuscular hip dysplasia, a migration percentage over 30% correlates to a higher risk of subsequent displacement. The migration percentage is the cornerstone to early identification. It is the percentage of the ball that is outside of the socket. And the migration percentage greater than 30% leads to an increased risk of progressive displacement over time. A supine AP pelvis X-ray establishes the migration percentage for both hips. This has a low radiation exposure, only about 60 millirems. Consider that the average annual radiation exposure at sea level is 300 millirems, even higher if you live above sea level. And if, say, you're traveling by air, you have radiation exposure of about 0.5 millirems per hour. Proper positioning for a supine AP pelvis X-ray involves the following. The hips should be positioned at neutral, with the patella facing forward, and the pelvis should be horizontal. If a hip flexion contracture is present, pillows should be used to keep the pelvis facing forward. And without pillows, notice that the hip flexion contracture tilts the pelvis forward. Here's some examples of what happens with rotation and tilt of the pelvis. The larger image here shows the properly rotated pelvis. If the child is improperly positioned in rotation and rotated to the right, as you can see in the upper right image, there starts to be difficulty in assessing the pelvic landmarks. If the child has a hip flexion contracture and pillows are not used, the pelvis tilts anteriorly, and now it's very difficult to see some of the landmarks of the pelvis. Again, the critical migration percentage is 30%. Now, interestingly, if you get an X-ray and look at the X-ray report, many times if the migration percentage is around 30%, the report will look like this: no evidence of subluxation or dislocation or evidence of hip dysplasia, a normal AP pelvis X-ray. Measurement is important. You or somebody else who's qualified and able to measure and look at the X-ray must measure the migration percentage. Otherwise, the trends over time will be invisible to you. The methods of measuring migration percentage are as follows. You can draw vertical lines and measure distances on a PACS workstation, as demonstrated here. This requires a calculator and a little bit of time. If you're lucky, you might have a computer-aided digital templating system that allows you to simply move lines on the X-ray, and the system will then automatically give you the migration percentage. Much of this is not available to people, and so we developed the Hip Screen app that actually has a feature where you can take a picture of an X-ray and then measure the migration percentage easily directly off the screen. It looks something like this. You select the migration percentage ruler, then take a picture of an X-ray. It can be on the computer screen, even a printed X-ray. Then you can rotate it so that the X-ray lays level on the screen, and then a ruler overlay is applied, allowing you to expand the femoral head until it touches the important and relevant parts on the ruler that then divide the femoral head into 10% increments, allowing you to easily measure the migration percentage directly off the screen. We recently published the results of this method of measuring migration percentage in the Journal of Children's Orthopaedics, and we found that it was as accurate as computer-aided or manual digital measurement, with an acceptable error of migration percentage. It had excellent reliability and was essentially equivalent to the other methods. Finally, we found that it was significantly faster than manual measurement, faster by about a minute, and clinically equivalent to commercially available computer templating methods, only 7 seconds slower. We'll go over this method of measuring migration percentage in a future tutorial. The final very important pillar of hip surveillance is the physical exam. Regular exams are very important, and we should be asking children at each of these appointments whether they're having hip pain or worsening function, whether there's been a change in the hip range of motion, and we should be evaluating the children to see if they have any of these high-risk issues: windswept leg deformity, scoliosis, a leg length difference, hip adduction and flexion posturing, or hip adductor spasticity. If there was one physical sign that's the most important, it's hip abduction, taken either in flexion or extension. And passive hip abduction less than 30% suggests that the child may be at increased risk of progressive displacement. When a hip surveillance strategy is used for the entire population, as it was in Sweden, it allows for the prevention of dislocation of the hip in children with cerebral palsy. This was a landmark article published in 2014 that showed the results of a 20-year population-based prevention program, one of the best pieces of evidence that we have that hip surveillance works. In Sweden, the hip surveillance led to an increased rate of early-stage preventative and reconstructive surgeries and decreased the rate of less successful salvage surgeries in cases of hip dislocation. As you can see, before surveillance, the rate of overall surgery was relatively low for preventative and reconstructive surgeries, but there was a significant amount of salvage surgery performed. These are surgeries that are less effective for children because they involve removing parts of the hip completely, rendering the hip more floppy and less functional. In the first 10 years of hip surveillance, salvage surgeries were eliminated, and in the second 10 years, the number of preventative and reconstructive surgeries went up as well. Now you may be asking, is this a strategy of surgeons to just do more surgery? Well, if you look at what happens to the percentage of hip dislocation over time, the story tells itself. Early intervention essentially eliminated hip dislocation across the entire population of Sweden. Our colleagues in Australia found a similar trend with a hip surveillance clinic that identified children early. They found that preventative surgeries increased over time, reconstructive surgeries decreased over time, and salvage surgeries were altogether eliminated. Hip surveillance works, and there are several guidelines that you can use for hip surveillance in your community. The Swedish guidelines are the oldest and were instituted in 1994. The Australian guidelines in 1997 and then revised in 2014 include a group 4 hemiplegic gait pattern recommendations and also recommendations on decreasing the amount of x-rays if the migration percentage is found to be stable. The British Columbia guidelines include many of these features, and most recently, the American Academy of Cerebral Palsy and Developmental Medicine released guidelines that incorporate the lessons learned from all of these guidelines previously. Information from Australia and Sweden also led California to establish hip surveillance as the standard of care for children across the state. I hope that soon Maharashtra would be included in the group of regions that has established hip surveillance as the standard of care. Let's talk about some of the barriers to implementation of hip surveillance. And these are quotes that you hear very commonly. The guidelines are too complex. We don't know how to read an x-ray. Measuring an x-ray just takes too much time. And my radiologists don't measure the migration percentage. We created hipscreen.org to overcome these barriers. If you go to hipscreen.org, you can download the free app as well as see all of the resources that are there online. It's available for both Apple and Android devices. On the first tab of the app, you'll find educational material on hip surveillance formatted in PDF for easy sharing, including why to do hip surveillance and the evidence behind it, how to interpret an AP pelvis x-ray. There are details for a radiology department, a protocol that allows the department to properly position the child, and instructions to the radiologist on how to measure migration percentage. There's also a description of the level of functions as described by the Gross Motor Function Classification System, or GMFCS. And finally, all the guidelines for hip surveillance are there at your fingertips. The second tab on the app allows you to touch the child's gross motor function classification system level, and then the recommendations are easily there for you to read about how often the child should be obtaining clinical exams and pelvis x-rays. Finally, the app contains the tool for migration percentage measurement, the migration percentage ruler, as I demonstrated to you earlier. The website has all of the complete hip surveillance guidelines, PDFs of the material available on the app, as well as video tutorials. I hope that you use HipScreen to make hip surveillance the standard of care in your community. Thank you so much. I've included my email address here for any questions.